that I don't necessarily see at Tampa General or at the VA. So that would be great. We will definitely get that set up. So I want to make sure we have enough time for what is going to be a great grand round. So welcome everybody to the Roy Benke Department of Internal Medicine Grand Rounds for a wonderful Thursday. We have a I'm very excited about today's speaker who I met last week at Dr. Aiken's Grand Rounds, and I want to thank everyone for a very good in-person response, a good in-person audience for Dr. Aiken, and online also was extremely strong. Dr. Aiken really felt welcomed, so wanted to give you that feedback that as we bring external speakers, for them to go back to their programs and state the hospitality and the incredible nature of their visit is important for us to hear, and it really enhances our national reputation. So thank you to Dr. Mosley for his support in bringing him here, and of course Dr. Tabatabian, who was instrumental in bringing the allergy component and the allergy team there. And I know we had a great time. As we move forward now, we hit a system which the mast cells don't disturb much, right? The renal system, as we heard last week. Dr. Akram Audi is an assistant professor in our division of nephrology and works very closely with Dr. Basile, our division director with Claude Basile, in the onconephrology section at the Moffitt Cancer Center. Dr. Audi completed his medical school and his initial residency in Beirut, Lebanon, and came to the U.S. and he did his residency in the U.S. at the Rochester Regional Medical Center, Unity Health Hospital System, then moved on to his nephrology fellowship at the University of Rochester Medical Center in Rochester, New York, as we were talking, where snow falls in late March, rarely in April. From there, he decided to see how late snow could fall in Iowa, and went to Iowa, where, of course, there's Field of Dreams baseball and there's Field of Dreams nephrology. And he did an amazing job at the Southwest Iowa Regional Medical Center, running their inpatient dialysis units, as well as being the medical director of 3 of their outpatient centers. We are very blessed. After 5 years in Iowa, he decided to be tired of those experiments, how late snow could fall, wanted to see the goodness of Florida, and joined the fantastic team of Dr. Basile as division director here at USF Morsani. He's already into double-digit publications and presentations, and his scientific achievements, I think, are going to be great in this career. We're so excited to watch him grow here at USF, and today he's going to give our grand rounds Hypercalcemia of Malignancy. Dr. Audi, take it away, please. Thank you.
Thank you, sir. Thank you, Dr. Lezema, and thank you all for being here today to join me in my grand round. First, I want to express my gratitude and my happiness to be part of the USF family. I've been here for 5 months, but I feel that it's been the best 5 months of my life. So thank you all for your hospitality and really guidance throughout this process. And I hope that everyone can see my slideshow. So I want to thank you.
It's coming out perfect.
Thank you. So again, thank you all for joining me to my grand round today. And today I'll be talking about hypercalcemia of malignancy, which is a quite interesting topic. We see it both in the inpatient and outpatient world. So it'd be important to shed the light on some of the important messages and updates on this condition. And I hope that by the end of this topic, I'll be able to give you a nice kind of overview of this complication of cancer. So to start with, allow me to begin with an outline. We're going to review some cases initially, and then go to the importance of recognizing hypercalcemia of malignancy. We will talk about etiology of hypercalcemia of malignancy, and for the sake of abbreviation, I'll be representing HOM as the disease. Then we'll move on to the different pathophysiology patterns of the hypercalcemia of malignancy. And finally, we'll talk about the treatment of the hypercalcemia of malignancy. So starting with the first case I want to share with you today, it was 70, and those are all cases I saw actually within those 5 months. So those are cases here. 75-year-old male presented to the ER with decreased appetite, decreased oral intake for 2 weeks, sour taste in the mouth, and constipation. His past medical history was significant for well-controlled HIV, hypertension, hyperlipidemia, and type 2 diabetes mellitus. He was newly diagnosed with the type of cancer that I'm gonna just keep to myself for now and share later on shortly. Results on presentation, normal sodium, potassium, and bicarb. His creatinine was 3.4 on presentation, which is definitely much higher than the baseline of 1.2. His calcium was also significantly high at 14.6. The rest of the labs were okay. So, in front of the hypercalcemia, initial workup was done, and this included the PTH, which was 36, normal range. The vitamin D was 24, slightly below goal. PTH-related peptide was 4.5 picomole per liter, which is above normal. And the 125 vitamin D, which is the active form of vitamin D, was 210 almost picogram per milliliter, which is significantly elevated. So in front of all these findings initially, we had PTH-RP positive, 125 vitamin D. Definitely this is explained by the malignancy. And as a matter of fact, he had newly diagnosed diffuse large B-cell lymphoma, which is a non-Hodgkin lymphoma, 1 month prior to presentation. So it was just a recent diagnosis. What was the therapy he got? Initially, he received 2 liters of normal saline bolus, isotonic fluid, followed by maintenance normal saline at 100 cc per hour. He also received zoledronic acid bisphosphonate 4 milligram one time, followed by calcitonin 280 units every 12 hours for 48 hours, and lastly, dexamethasone 40 milligram daily for 4 days. On discharge, the calcium was 9.6 and the creatinine was 1.9. So back to normal. The calcium and the creatinine was improved, but not back to baseline yet. Now, the second case is a 53-year-old male who came to the emergency room with abnormal labs found as outpatient with hypercalcemia and the suspicion of tumor lysis syndrome. Past medical history was asthma, anxiety, depression, hypogonadism, and the malignancy, which we will share shortly. Blood work results on presentation also showed the sodium of 134, potassium 5.3, bicarb was 28. However, creatinine was higher than baseline, 1.8. Calcium was also elevated at 13.2, moderately elevated, and the rest were acceptable. In this workup for the hypercalcemia, the PTH came back 14.9, so you can tell it's really on the low side of normal, even a little bit suppressed. 25 vitamin D was 16. PTH-related peptide was less than 2, normal range. And the 125 vitamin D was 333, so significantly elevated. So this case has also vitamin D elevation like the first case, but we don't have the PTH-RP elevation. As a matter of fact, this patient had relapsing, also non-Hodgkin lymphoma, with manifestation of hypercalcemia. Therapy received, it's a bit similar to the first patient with bolus of 1 liter here instead of 2, with a maintenance of normal saline 100 ml per hour, zoledronic acid 4 milligram, calcitonin again, and he received oral prednisolone here as part of the chemotherapy regimen for the treatment. Now, not all the patients will be able to have the IV fluid, and we will talk about that a little bit shortly, because actually just a few days ago I was on call and we had a patient coming also with hypercalcemia, calcium of 16, but this patient who has also cancer had at the same time hyponatremia, sodium of 127. So what happened is when they gave her IV fluids, the sodium went down to 126. So basically what this patient had was SIDH along with the hypercalcemia. And those are tricky cases because you really have to be careful with the IV fluid. So in that case, actually, we held off on further fluid and we managed with the other tools which we had, which were the bisphosphonate and the calcitonin. So IV fluid is not always the first and best answer. On discharge for this patient, our second case, calcium was corrected to 8.5 and then corrected to albumin 9.4, and creatinine was back to baseline. Our third case which is also a very interesting one. A 70-year-old male came into the emergency room due to infected lower extremity wound. Now, prior to the admission, he was at a different hospital with fracture, and he got surgery for that. Past medical history is significant for hypertension, polysubstance use, hepatitis B, and hepatitis C. Past surgical history was significant for left nephrectomy years ago. Presentation, in summary, the creatinine was basically elevated, mostly from 1.86 months prior to admission. Now it's 2.8. Calcium on presentation was 9.5. So he came to the hospital with normal calcium level. Nephrology was initially consulted for the acute kidney injury, but then we signed off, and then we got reconsulted again when the calcium this time was high with ionized calcium 1.6 millimole per liter. If you don't mind, follow me on this graph here to highlight the creatinine trend during this lengthy, I would call it lengthy hospitalization, where the patient was from December to February. You can see how the creatinine initially was high on admission. It improved without never getting back to baseline, and then it got back high again towards the end of January of this year. Now, if we take the calcium trend also in the same fashion, we can see that the calcium initially was normal, but during the hospitalization, calcium was showing to have elevation, and the peak was almost showing during the whole month, I would say, of January, with a peak of 11.5, and then calcium by the end of January started improving. And if you can see, the peak of calcium preceded by a few days the peak in creatinine. Now, initially he had normal, I would say even a little bit on the low normal side PTH when he first came in. But then when he developed hypercalcemia, the PTH was 4.0 suppressed. The 25 vitamin D was 34. PTH related peptide was 21, borderline elevated, just a smidge elevated. And the 125 vitamin D was suppressed, actually was 10. To complete the workup, monoclonal protein workup was done with slightly elevated kappa over lambda free light chain ratio, not very significant. SPAP was showing no M spike, and the serum immunofixation had no monoclonal paraprotein. Interestingly, on the CT scan of the chest, there was found to be multifocal lytic bony lesions, including manubrium and the ribs. A CT-guided biopsy was effectively done on the manubrium, and the result came back as poorly differentiated metastatic carcinoma. Further testing showed positive PAX8 positivity, which at that case raised the possibility of renal primary tumor. So going back a little bit to the history, now we remember that he had left nephrectomy, so probably his past cancer now has shown metastasis in this bony lesions, which then explain the hypercalcemia. So this is really a nice illustration of how a patient coming with normal calcium can develop hypercalcemia in the hospital, and it ends up being from cancer. It could have really been blamed only on immobilization, but really thanks to the very nice workup done, really the final diagnosis was found. He received in this case only IV fluids because calcium was 11.5, just mildly elevated. And on discharge, calcium was back to normal with follow-up with oncology arranged for the patient. So, important reminders just quickly about those three cases. What I want you to remember is that one specific type of cancer can cause the hypercalcemia through different mechanism. If you remember, the non-Hodgkin lymphoma had sometimes elevated PTH-RP and vitamin D, sometimes elevated vitamin D alone. So different mechanism can happen within the same one cancer. The patient who developed hypercalcemia while hospitalized was found to have cancer. So that's important to remember. And the treatment of hypercalcemia of malignancy involves multiple therapeutic agents that sometimes can be all used at the same time. So moving forward to the second part of my grand round, I would like just to highlight the importance of recognizing hypercalcemia of malignancy. Why do we really want to just talk about it in our onconephrology world? Because basically the hypercalcemia frequently complicates the care of patients with cancer. Hypercalcemia can occur up to some studies up to 30% of all cancer patients. So during their course of their disease, cancer patients are estimated to have between 20 to 30% of them will develop at some point hypercalcemia. So it's not a low number at all. malignancy remains the most common cause of hypercalcemia in people in the hospital. So this is also something important for the inpatient management, that hypercalcemia found in the hospital has to be really worked up, not only the outpatient hypercalcemia. And patients who we are able to reach normal calcium levels for, and who have cancer and who received chemotherapy, had longer survival, and that's key because really want to increase survival for these patients. And that's all data from the New England Journal of Medicine. Going a little bit to kind of a quick reminder to all of us on, which is going to be helpful both inpatient and outpatient reminder, really how to work up hypercalcemia initially in these patients, and basically in every other patient, but mostly in cancer patient later on. But initially with patients presenting with hypercalcemia without a diagnosis, you have to start with the initial tool, PTH, very helpful. If you get normal to high PTH, you will shift your attention to the left side of the algorithm, where you have PTH dependent hypercalcemia, and then options could be most likely primary hyperparathyroidism, sometimes familial hypocalciuric hypercalcemia, but those are not the topic of my talk. I'm not going to dwell a lot on them. On the other hand, on the right side of the screen, you can see the PTH being suppressed, and this has to raise our suspicion to more workup to be done, namely PTHRP, vitamin 125 vitamin D, monoclonal protein workup, imaging sometimes with skeletal survey, for example, to rule out multiple myeloma. But let's say we have low PTH initially, then we have to do this workup. And then depending on the findings we have, if we get high PTHRP, then we think more of a cancer. If we get high 125 vitamin D, it still could be a cancer. It still could be sarcoma or other granulomatous disease. If we get multiple myeloma workup positive, then we know mostly that we are dealing with multiple myeloma. And if we have alkaline phosphatase high, we know that there is some process causing bony lesions as part of metastasis. So this is just quite a quick reminder of how to work up hypercalcemia in every patient. Now, what are the clinical manifestations of hypercalcemia? Basically, we divide them into the severity of the hypercalcemia itself and the different organ systems that it attacks. The hypercalcemia can be mild initially between 10.5 to 11.9, moderate when it's 12 to 13.9, and severe when it's above 14 milligram per deciliter. The first organ system, the cardiovascular system, we can start with anything that can shorten QT interval manifestation, prolonged PR, up all the way to arrhythmias, even cardiac death and cardiac arrest. When hypercalcemia is mild on the GI system, we can see symptoms such as constipation, which is a common manifestation, anorexia, poor appetite, going even a little bit more symptoms in the moderate hypercalcemia, and all the way to pancreatitis and peptic ulcer disease when hypercalcemia is severe. Regarding renal manifestations that are really important to us as well, we could even start having polyuria with mild hypercalcemia, which is very important. This can go all the way to dehydration and even leading to acute kidney injury. Neurological system, we can start with anxiety, depression, patients having some behavioral changes, all the way to altered mental status and coma and lethargy. And for the musculoskeletal organ, usually it manifests as weakness. Now, very important point I want to just shed the light on really quick about the acute kidney injury, because we saw earlier in the slide that one of the manifestations is acute kidney injury, and we always tend to find the reasons for the acute kidney injury when we have hypercalcemia, but we have to know that the hypercalcemia itself is a risk factor and is a culprit in AKI. And allow me to show you how exactly. The first mechanism is by vasoconstriction. Hypercalcemia, when the calcium concentration is high, it will cause vasoconstriction of the small vessels in the kidney and to the vessels delivering blood to the kidney, which will hinder the perfusion, hence lower the filtration rate, and by that, it will cause kidney injury. The second important mechanism is volume depletion. So people with hypercalcemia tend to have volume depletion. And the reason for that is that when the calcium level is high in the blood, it will downregulate the aquaporin 2 water channels, which we know very well, regulate the kind of sodium and water balance in the blood. So downregulates the aquaporin 2 channels in the collecting tubule and Also, hypercalcemia, don't forget, it can cause tubulointerstitial injury, tubulointerstitial inflammation caused by the calcium deposition. Those two together will give you a defect in the ability to concentrate the urine. And when you're not able to concentrate the urine, automatically you will have polyuria. So polyuria and volume depletion added to vasoconstriction will give you AKI. So this is really something important to know, both outpatient and inpatient. Moving forward to the third part of the grand round, I would like really to highlight the etiology that are the mostly two most common etiologies of hypercalcemia of malignancy. Why do people with cancer develop hypercalcemia? Initially, we have the bigger kind of category would be humoral hypercalcemia, meaning coming from hormones secreted and in an endocrine way, hormones that go and circulate in the whole body. Namely, we have PTHRP, which is by far the most common, about 80%, I think. And we have non-PTHRP, which is mostly the 125 vitamin D. And the other big category here that we have to remember is the bone invasion, mostly metastasis. The third and less common category of causes for hypercalcemia of malignancy could be drugs medications that patients with cancer receive, such as retinoid therapy, could be immobilization for the patients, and could be in rare cases PTH itself, and not PTHRP, PTH secreted by certain types of parathyroid cancer. But in general, it's two big categories, humoral versus metastasis. Now, what are the different pathophysiologies included in the development of hypercalcemia of malignancy? For the pathophysiology, I chose really this picture that I really want to just ask you to share your attention with me on this picture, because it depicts very nicely the two big categories that we just spoke about. But not only that, it explains to you the mechanism of hypercalcemia. And it's also always nice to know the why of things, and not only what are the things. So here is the why. First big category is humoral hypercalcemia. As we mentioned earlier, this is through hormones. But how does this happen? If you follow me on the left side of the screen, they took an example of lung cancer. But basically, it could be lung, could be breast, could be parathyroid, could be head and neck, could be urothelial. These kind of cancers are known to secrete hormones. What are these hormones? It's mostly 125 vitamin D. It is also PTH-related peptide, and some of them secrete both. Now, when these hormones are secreted, they don't stay local. They go and travel in the body. So what happens is, when you have the 125 vitamin D, it can go, and as shown on the graph, it will act on the intestines. And here it will increase the absorption of calcium, phosphorus too, but mostly calcium. Hence, you have more calcium absorbed in the body. The second mechanism would be how the PTH and the PTHRP mostly would go and act on the kidney. So it's not only the intestines and the bone, the kidneys are also playing a major role in the development of hypercalcemia. How are the kidneys involved? We will see later on a few slides that detail more this mechanism. But for now, what I want you to remember is that the PTHRP and the PTH will act on the kidney to increase the reabsorption of calcium. And third, and most common, is when the bone is affected by the PTH and PTHRP. And so when the bone is affected by the PTHRP, and in this case, I would like you to follow me with the small magnified window on the lower left side. The PTHRP going to the bone will basically come and act on the PTH1 receptors. Those are the same kind of receptors that the PTH would have acted on. But in this case, it's the PTHRP that comes and acts on those receptors. What happens next? Well, it's quite interesting. The PTH1 receptor, once it's activated, it will downregulate what we call osteoprotegerine. Osteoprotegerine is there to protect from bone resorption and to favor bone formation. When you downregulate OPJ, what's going to happen is that you will favor the binding between the receptor activator nuclear factor kappa, what we call rank ligand, and the rank receptor. Once you have these two binding together, the precursors of the osteoclast, let's say the bad bone cells, the receptors of those cells will be activated. But actually, those cells are not really bad because they are essential to every one of us. But those cells will be activated, will mature, and then will lead to more bone resorption, and hypercalcemia will happen. So this is how the humoral hormonal part plays a role in development of hypercalcemia. Now, if we go to the right side of the slide, this is the part of the metastasis and how the cancer can cause hypercalcemia by metastasizing. They took an example of the breast cancer. It could be also lung, it could be renal, it could be other cancers. What happens is that the cancer cells, once they go and they sit on the bone, they will basically also okay, they will also do the PTHRP will also bind to the PTH1 receptor the same way. The PTHRP will go and sit on the PTH1 receptor the same way, and the same mechanism will happen basically by dropping the OPG regulation, favoring the rank ligand and the rank activity, and then causing osteolysis and release of calcium. But the interesting part to know in this mechanism is that those tumor cells, when they go and they sit in the bone, not only they release PTHRP, but they also release other factors such as interleukin 6, 11, tumor necrosis factor, MIP, and those factors also are incriminated in the activation of the rank ligand and rank receptor, hence leading to activation of the osteoclast. And what's also further important is that when those osteoclasts become mature enough, they will themselves secrete what we call tumor growth factor and IGF factors. And those will cause the metastasis, the tumor, to grow even more. So it becomes like a vicious circle. The tumor secretes hormones, and then the osteoclast secretes hormones, and then it's kind of vicious circle keeping the process going on. So in summary, those are the two big mechanisms by which cancer can cause hypercalcemia. Now, one third mechanism I want to also share with you, it's because we see it a lot also in the cancer center. Multiple myeloma is notorious for causing hypercalcemia. And really the quick and nice explanation is that those plasma cells, as you know, the plasma cells will release DKK1, DKOF1 protein. This protein plays a major role in increasing osteoblast suppression. And by increasing the suppression of osteoblast, you favor resorption and hypercalcemia. Now, why are we talking a lot about PTHRP? Because in fact, it shares a big part of its amino acid components shares it with PTH, and mostly in the N-terminal signaling fragment, which you can see lots of similarity in the sequencing of the amino acids are present there. This N-terminal signaling fragment is the same one that binds on the PTH receptor. This is why the PTHRP and PTH can both act on the PTH receptor the same way. PTHRP was first actually thought to be, or initially they called it PTH-like factors, and they were thought to be incriminated in the hypercalcemia of malignancy in the 1940s by Dr. Albright, and he published his manuscript back in New England Journal of Medicine in 1941. But it wasn't until the late 1980s that the active principle responsible for the syndrome was identified as PTHRP, due to its also homology in the N-terminal sequence to PTH. And PTH exerts cellular activity through the binding and activation of the receptors, which we already mentioned. Now, what is important to remember is that with PTHRP especially, there is not one only type of pathophysiology. It can be a spectrum, meaning PTHRP can both act locally as a paracrine factor causing coming from metastasis, but can also come from the cancer itself in a humoral way. When it's coming from the cancer in a humoral way, the levels will be high in the blood, so this is how you will catch it. Whereas when it's coming from a local metastasis, usually PTH level will be low because it will not have the capacity to show as high levels in the blood. It's only acting within its vicinity, locally in the bone. So having said all of that, what you can ask me that why haven't we found treatment for that? Well, basically, there has been some actually multiple attempts to find a treatment for the PTH-RP. If you can treat if you can kind of disable PTH-RP, maybe you would be able to kind of avoid hypercalcemia in many patients with cancer. But unfortunately, up until now, this has not been successful so far. And how does the PTH-RP affect calcium in the kidneys? Which, you know, I was going to also point on that mechanism too. Well, first, let me tell you that the homeostasis of calcium is mostly regulated in the thick ascending limb of loop of Henle and the distal convoluted tubule. So if you see on this graph, the PTH here, which is basically, if you want to consider it, let's talk about PTH-RP, since we said they share the same N-terminal peptide. The PTH-RP will come and will bind to the receptor. And after the receptor is activated, it will also activate the cyclic adenosine monophosphate, as you see on the right side. And this activation will also activate channels we call Claudin 16, Claudin 19. Hence, the calcium will be absorbed from the luminal side to the basolateral side. And the second mechanism where PTH-RP will act on the kidneys is on the distal convoluted tubule, where you see that the PTH, by activating the PTH1 receptor, will also activate CAMP, and this time through the channels called TRPV5, they will get the calcium absorbed from the luminal side to the basolateral. Then there is an exchange with the calcium and with sodium, and then the calcium will go to the blood. So in summary, I'm focusing on PTH-RP to tell you that it really plays a major role, even to the point where I can tell you whenever you have PTH-RP elevation, you have to really think of cancer and start, you know, work up for that. PTH-RP initially, you know, embryonically helps physiologically, but, you know, after birth and at adult age, its levels should not be elevated. So this is just an important message I want to share. We see that it acts on different parts of the body, the kidneys, the bone mostly, and on the bone, when it activates the osteoclast, as we said, becomes a vicious circle, because those bony cells will secrete tumor growth factor, making the tumor grow more, and it becomes perpetual. Now, to summarize about the pathophysiology, which we dwelled a little bit, but because it's really the gist of the topic, two big parts: humoral hypercalcemia, where the hormones are secreted by the tumor, and they go do their job by proxy, or local osteolytic hypercalcemia, mostly metastasis. In the humoral part, when you find PTH-RP elevation, you have to think lung cancer, breast cancer, renal cancer, and many others. When you have 125 vitamin D, it's more limited to lymphomas. When you have PTH, it's more rare, but you think of parathyroid cancer. Whereas when it's metastasis causing the hypercalcemia, you think definitely PTH-RP. Sometimes, as you saw in the one of the cases we saw, PTH-RP was elevated despite having also bone mets. So PTH-RP could be high in breast, lung, and kidney. But then also the responsible factors would be also in multiple myeloma, as we said earlier, DKK1 protein and so forth. So you have two big types of mechanism that explain hypercalcemia. Going to the treatment of hypercalcemia of malignancy, I want to just also spend a few minutes on this important slide, because as we said, most of our patients have received IV fluids initially. Most of them usually will be a good candidate for IV fluid. Just be careful when somebody has SIDH from the cancer, when somebody has volume overload, we have to be very careful with the IV fluid. The second treatment I would like to touch base, which we commonly use also, is the calcitonin, which is this hormone that's usually secreted by the thyroid, and its role is to actually protect the bone, limit the bone resorption, increase bone formation. So calcitonin, we give it at the dose of 4 to 8 international units per kilogram, usually every 12 hours for 48 hours. The mechanism of action is inhibition of the osteoclast and increasing of the calcium excretion by the kidney. The only problem is that there is some tachyphylaxis, meaning when the effect after 48 hours or winds down, you could see a jump again of the calcium. But I think by that time you would have maybe given bisphosphonate or denosumab, and then you would have better control of the calcium. Moving forward to bisphosphonate, so this is also very, very common treatment for hypercalcemia of malignancy. So important things to remember about bisphosphonate is that they inhibit the osteoclast activity. And how do they do that? By acting directly on the bone matrix. They go inside the bone matrix and they deactivate and even cause the death, the apoptosis of the osteoclast. So this is how they protect the bone. The problem is that sometimes we can have some side effects such as flu-like symptoms, bony pain, also the renal problem we're going to talk about shortly, kidney injuries, osteonecrosis of the jaw. So it doesn't come without possible side effects. Usually the nice thing is the, the good thing is that within 2 to 4 days the effect will kick in. So it's relatively acceptable time frame, given that we can initially control the hypercalcemia with IV fluids and calcitonin. And at the same time, denosumab is also a medication that has been used and that is being used for hypercalcemia of malignancy. The mechanism of action is impairing the osteoclast activity. There is this medication also can start showing effects within 2 to 4 days after injection. The nice thing is that it can be given subcutaneously, so I personally like this option. Definitely side effects are possible, such as bone pain, diarrhea, osteonecrosis also, and risk of infection. And also something you need to remember, the hypocalcemia. Hypocalcemia can happen, days after the denosumab, but this is not very, very common, but it's still a very good medication. So those are the 4 categories of medications usually, that are the most used. I wanted to add this slide also to tell you that the steroids, if you see the bottom of this table, steroids also play a role, but mostly where in the lymphomas. You can start with hydrocortisone IV initially for 3 to 5 days, and then move to oral prednisone to complete another 5 to 7 days. Sometimes I've even given oral prednisone from the beginning when I feel that IV would be maybe too much on the patient. But steroids will be also a good option for lymphoma.
This will be loud. This will be loud. Sorry.
And so the next slide will be the kind of the reason I'm putting it is because the dialysis is sometimes a last resort for people who will have hypercalcemia that we're not able to control. That we're not able to control with other measures. I apologize. And then people with volume overload, you can see that the diuretics, loop diuretic namely, are always a very good option to use. Not first choice, but people with volume overload, after you give them IV fluids, you could use loop diuretics, which at the same time can help with calcium excretion. Now, the next slide I want to shed a light on is the IV bisphosphonate, which we use commonly in the hypercalcemia of malignancy. The reason I'm putting this slide is to tell you that the use of the bisphosphonate will vary depending on the level of the kidney function, meaning both the dose and the frequency of the bisphosphonate will depend on the level of the kidney function. So when the kidney function is acceptable, you could use regular doses. When clearance is between 30 to 60, you have to lower the dose. When clearance is less than 30, you have to increase the interval of the medication. Even Zometa, zoledronic acid, you cannot use if the clearance is less than 30. Now, a few things to remember also from the nephrology world, that pamidronate has nephrotoxicity, and typically, we know that it can cause nephrotic range proteinuria and nephrotic syndrome by the collapsing FSGS. Zoledronic acid also can cause nephrotoxicity and is mainly associated by the ATN it can cause, and I've personally seen ATN happening after zoledronic acid. So you can see that both have a profile of toxicity, but we prefer zoledronic acid if we want to start by using IV bisphosphonate. This is a study I'm highlighting to just shed the light on the comparison between zoledronic acid and pamidronate in treatment of hypercalcemia of malignancy. So what happened is here we had patients with moderate to severe hypercalcemia of malignancy, and they were treated. They were treated with zoledronic acid with 2 different doses or with pamidronate, and they wanted to see which one of those bisphosphonates was superior in reaching resolution of the hypercalcemia. 285 patients were randomized and 275 completed the study. Both doses of zoledronic acid were superior to pamidronate in the treatment of the hypercalcemia of malignancy. The complete response rate by 10 days were 88% and 86% for the 2 doses of the zoledronic acid versus 69.7% for the pamidronate. And normalization of calcium occurred by day 4 in about 50% of patients with zoledronic acid and only 33% of patients with pamidronate. Okay.
Is that the hypercalcemia alert every time somebody has hypercalcemia in Moffitt?
So
That's the bad signal for Dr. Basile and Dr. Audi to get to treating hypercalcemia.
And so the next part would be I want to shed light on denosumab because it's really kind of a therapy that is there. We don't use it maybe much, but it's very important to know about because it is going to be really helpful. It's not very new medication, but some data are showing that denosumab could even be used as first-line treatment for hypercalcemia of malignancy. Here in a study coming a few years ago, they even, it was not a big sample, but they really wanted to start and see if this really is efficient. So they took 15 patients, 18% have achieved normalization of the calcium within 4 and 8 weeks of the therapy. So denosumab has shown efficiency and good results with hypercalcemia. Now, what is denosumab and how does it work? Denosumab is basically a monoclonal antibody, but this picture here I wanted to put to remind you of the osteoblast and osteoclast interaction and how the bone homeostasis is controlled. As you can see, the osteoclast precursors have rank receptors, and those rank receptors will receive the rank ligand, and once they are activated, they mature and they cause bone resorption. Where does the rank ligand come from? From the osteoblast, because it's a very kind of very thin kind of balance that happens between those two cells. And osteoprotegerine in blue, you can see it, is actually acts like a buffer. It comes and it binds to the rank ligand, and it prevents the action of the rank ligand. Hence, basically, it lowers the maturation of the osteoclast. So it protects the bone from resorption. So what does denosumab do? Basically, if you see on this window, denosumab is a monoclonal antibody. So the nice thing of it acts in the space without entering the matrix of the bone. If you see below those red circles, those are bisphosphonate. Bisphosphonate will go inside the bone matrix and cause basically apoptosis of the osteoclast. Whereas denosumab will come and will act in the space that has the rank ligand. It will bind to it, deactivate it, and hence it will act on preventing the activation of the maturation of the osteoclast. So two different mechanisms, those two medications. Comparing here bisphosphonate to denosumab, in this article too, you could see that the most important part is that bisphosphonate are enzymes, denosumab is monoclonal antibody. The specific effects, basically, definitely the bisphosphonate, as we mentioned, goes into the matrix. The problem with that is that it can stay in the matrix for months and months before it gets kind of eliminated. denosumab will actually act on the as a monoclonal antibody, deactivating the rank ligand. Bisphosphonate cause cell death, whereas denosumab inhibits cells. And then onset of action, usually it's the same. As we saw earlier, 2 to 4 days, which is very acceptable if we're aiming for long-term success. But the problem is that bisphosphonates are eliminated by the kidneys, whereas denosumab is not cleared by the kidneys. Denosumab is cleared by the reticuloendothelial system with a half-life of about 26 days. So up until now, direct head-to-head studies comparing denosumab to bisphosphonate in the initial treatment are very limited. But what we do know for a fact that what's better than treating the hypercalcemia? Well, it is preventing it from happening from the very beginning. So if we can reach a point where we can avoid hypercalcemia, and we won't be able to achieve it in all patients, but if we can do it in a considerable amount, we would be really doing kind of a breakthrough in this domain. So, and to that, they've been studying denosumab versus Zometa in preventing hypercalcemia of malignancy from the very beginning. And to that end, there's been a study done also a few years ago that studied denosumab versus Zometa for the treatment of bone metastases in breast cancer. What this study did was a randomized controlled trial that compared those two medications among people with creatinine clearance of 30 and above with bone metastases or multiple myeloma. Patients who were randomly assigned to receive either because they had to do it in a clever way. So what they did is one arm had the subcutaneous denosumab and IV placebo, and the other arm had IV zoledronic acid and subcutaneous placebo, because denosumab is subcutaneous. So they wanted really to just remove the confounding factor. And to that end, they found that denosumab had a lower incidence of hypercalcemia. It was, the difference is not too big, but it was statistically significant. So 1.7% had hypercalcemia, whereas almost double. So it's basically, but it cut it down by half, which is a nice result. The other study I want to highlight is coming from Europe this time. So it's the role of denosumab in prevention of hypercalcemia of malignancy in cancer patients also with bone metastases. And here what they did is, they also studied those two medications, and they found that denosumab delayed the onset of the first episode of hypercalcemia and reduced it really by 37%. So the hazard ratio was 0.63 with statistically significant confidence interval. So this was 37% reduction in the event of a first episode of hypercalcemia. And even if they all developed hypercalcemia, the risk of recurrence also was reduced by 52% if you use denosumab only. So really very promising results. So as we just said, it was good in both preventing the first episode and preventing also recurrence. So this is for the denosumab and how really promising it is. But one more thing I wanted just to add, and to really to make you aware of, that people with cancer are just like every other patient. So they can have malignancy of their hypercalcemia from their malignancy, and they can also be having primary hyperparathyroidism, for example. So concurrent existence of two primary causes of hypercalcemia is rare but possible. And management of both, for example, you could do parathyroidectomy and you can address the cancer itself. So management of both can lead to symptomatic improvement and better survival. Now, one last part I wanted really to highlight before I just give time to some questions is the multidisciplinary approach. As you may have noticed, and as other colleagues have maybe experienced that in their practice, hypercalcemia of malignancy, encompasses multiple specialties. We could have nephrology, we could have oncology, we could have endocrinology, and we could have pharmacy. So all four divisions could be on the same case. So putting the pieces together in a multidisciplinary approach is really very, very important in this disease. Joining efforts would lead to promising studies regarding, first of all, therapy targeting PTHrP. As I mentioned earlier, PTHrP is the really major culprit in humoral hypercalcemia, which is in itself is the major cause. So if you can target PTHrP and limit its bad effect, maybe you can reach a point where hypercalcemia of malignancy is really well controlled and even, avoided. And collaboration between different specialties can lead to head-to-head clinical trials to compare denosumab and bisphosphonate, because we're always going to have patients with hypercalcemia, even if we try to prevent it. But we need more studies to compare denosumab and bisphosphonate. People have been shying off maybe from denosumab. I don't know if it's because of the reputation of the hypocalcemia, or maybe the cost, or maybe, but I think, from my experience, it's a good medication. It's showing promise in the prevention of hypercalcemia. It's good for acute, moderate to severe hypercalcemia. The only thing I want to point your attention to is always check vitamin D. Vitamin D should be corrected before you give it, because it's counterintuitive. But yes, if you have hypocalcemia and you want to give denosumab, you can still give vitamin D and not be afraid of the hypercalcemia, because if vitamin D is low, you run into a bigger risk of hypocalcemia. So take-home messages after this grand round. I really would like you to remember that proper evaluation to make a diagnosis of hypercalcemia is essential to guide treatment. And people with underlying cancer will frequently encounter hypercalcemia in their cancer disease, and this warrants prompt treatment. You have to treat them really to improve the survival and to avoid symptoms, most importantly. Denosumab is a promising therapy to prevent hypercalcemia of malignancy, and we've only put 2 examples, but maybe more is to come as to how we can use denosumab to avoid hypercalcemia. And new studies about targeting PTHRP and PTH receptor sometimes are also needed to treat cancer-associated hypercalcemia. Here are the references for the talk of today, which I summarized in 2 slides. And again, thank you all so much for your attention and for participating in my grand round today. Thank you.
Thank you, Dr. Audi. We'll take any questions, and Jen will look at the chat. Fantastic talk, great clinical integration of cases, and just an impressive review of the pharmacotherapy and clinical trials. So thank you very much.
Thank you.
And yet we heard your hypercalcemia alert, so that was good. All right, we'll take any questions.
Yes, Joe, hey, Claude is here. How are you? Thank you, Akram, for a great presentation, great review in that short period of time. It's just so hard to summarize all the malignant hypercalcemia of malignancy. I just want to comment and add to what Akram said regarding the use of bisphosphonate for the audience, for the internists and specialists who are attending the lecture. So when we have abnormal kidney function, using Zometa or not using Zometa, it depends on the case. If the patient has signs of improvement on his kidney, because by definition the hypercalcemia causes pre-renal, so the patient, as if he's on diuretics when he has hypercalcemia, so giving him the fluid is a first step. If we notice his kidney is getting better, we should start the bisphosphonate early rather than late. Zometa is 100 times more stronger than the pamidronate, compares them both. If the patient has really abnormal kidney function not improving, as Akram mentioned, dosing it and giving a 60 milligram will still work and will still do the job, because the patient who has hypercalcemia of malignancy, their mortality is high. The 30 days or 60 days are really high. Regarding the denosumab, Prolia, Exiva, it's been approved initially in 2010 for the postmenopausal treatment, in postmenopausal treatment to prevent fracture in women and other type of cancer. We're using it off basically label when we have this patient. Well, where do we use it? We use it in patients who have bisphosphonate resistant hypercalcemia, which is a sign of their disease, as Akram mentioned in his talk. Most of the time that hypercalcemia end up being that these hormones, that whether they are secreted systemically or locally, they are activating the rank ligand, and by binding the rank ligand to the rank, it will activate the osteoclast. So when we have these things, we notice that using a monoclonal antibody to block the rank and prevent the activation of osteoclast is kind of exciting, right? It will be pathophysiologically treating the hypercalcemia in these patients. As Akram mentioned, yes, there are cases where we have severe hypocalcemia, and I would say severe hypophosphatemia that require hospitalization. But I would say here is, if I have patient coming my way and they're asking us whether this patient can be on either one, well, if his kidney is abnormal chronically, I'm okay to give him personally Exeva and ask the primary to, as Akram said, keep an eye on his labs weekly for like a couple of weeks to make sure no hypocalcemia and try to prevent these complications. But great talk, Akram. Thank you.
Thank you, Claude.
Yes,
Yes,
Dr.
Claude,
Diaz-Perez, go ahead.
comment on what you brought in is that you were talking in an outpatient setting. In the inpatient setting, which you are based on DRG, it depends on the hospital. Some hospitals got you blocked on using Exgeva because using biphosphonate is cheaper. So on a DRG basis, different from the outpatient basis in which you bill by drug administration, then it becomes sometimes a barrier too. But there are some patients that you may need to talk to pharmacy that you may not have any other option to use Exgeva.
Thank you.
Dr. Audi, I have a question. My name is Rosa. I'm one of the endocrinology fellows. And my question was more regarding the denosumab use and hypercalcemia of malignancy. So let's say I have a patient with a contraindication for getting biphosphonate, and I need to do denosumab, but the vitamin D it's very low. How would you replete this, and how long would you wait until you give the denosumab?
Of course. Thank you for this question. First, what I would do is I would give the 60 milligram instead of the 120. You could start with a lower dose of denosumab. And we need definitely to check the vitamin D when you get the result, depending on the severity. If it is really very, very low, you could maybe start with 50,000 units of ergocalciferol, do it weekly. And then, I wouldn't wait. If the hypercalcemia, is, severe, if there are symptoms, you need to bring it down. I wouldn't wait, make sure to trend the calcium, but you can start with ergocalciferol. Now, usually what you would see in the vitamin D in the teens, maybe 13, 17, 20 something. So those are usually okay. You can start if you have vitamin D very suppressed, less than 10, that's an interesting question, but still, me personally, I wouldn't hold off on denosumab. I would start aggressive vitamin D repletion with ergocalciferol, but I would not hold on the denosumab. What you can do is you can give a lower dose of denosumab of 60 milligram instead of 120.
Thank you.
And Akram, I will add, you can also, Dr. Rosa, use calcitriol in these patients. So not every hypocalcemia that happen in denosumab is really bad. I have this patient, they can be on 3 times a week calcitriol, active vitamin D, in case that happen. And as Akram said, you can do once or twice a week, 50,000, depending on the level. But again, this patient has high mortality. The point Akram is trying to make is you need to treat them, right? So I want basically hold on it. Again, more randomized trial needs to happen because it's been approved, FDA approved for the postmenopausal basically fracture.
Thank you so much.
Perfect. See, I think we've cleared the chat comments and from the comments, yeah, very good. Everybody's saying great talk, including our chair, Dr. Mosley. So very, very nice. To appreciate the positive feedback. It was outstanding talk. So we will conclude here. You all can contact Dr. Audi if you have further questions, but we'll end right on time. So thank you again, Dr. Audi, and I hope everybody has a great rest of the Thursday. Take care. See you next week.
Thank you, Dr. Lizama. Thank you all.
Thank you.